Hello everyone, my name is Dr. Sikandar and today we will discuss about the COPD Gold Guidelines completely from initiation to the end. So yeah, we will discuss all the tables here. So let's start. What are the proposed taxonomy like etiotypes for COPD? So like they have proposed first time in COPD guideline. So yeah, so there are like multiple taxonomy etiotypes like it could be COPD-G. COPD-G means like genetically determined. So what is its description? So they are telling like it could be due to alpha 1 antitrypsin deficiency or other genetic variant with a smaller effect acting in combination. So like other multiple genetic causes could be there, or either it could be alpha 1 antitrypsin deficiency. So it is COPD-G. Then there is COPD-D. COPD-D is like COPD due to abnormal lung development. So for D for development. So it is early life event including premature birth and low birth weight among others. So then comes COPD-E. COPD-C. COPD-C is cigarette smoking COPD. So it comes under environmental COPDs. So COPD-C is cigarette smoking COPD. So exposure to tobacco smoke, including in utero or via passive in smoking, or via vaping or e-cigarette use or cannabis. Then comes COPD-P. It means like biomass and pollution exposure COPD. P for pollution, C for cigarette smoking, D for development, G for genetically determined. So P for pollution means exposure to household pollution or ambient air pollution or wildfire smoke or occupational hazard. Then comes COPD due to infection. COPD I for infection. So because of childhood infection, tuberculosis associated COPD, or HIV associated COPD. Then comes COPD A, means COPD and asthma. So it is not like overlap. COPD A is a different thing. Means COPD is associated with COPD is uh, with asthma. So, like particularly, it used to happen in childhood asthma patients. Then comes COPD of unknown cause, means COPD U. So again, we will discuss COPD G means genetically, D for development, C for cigarette smoking, P for pollution, I for infection, A for asthma, U for unknown cause. Then comes what are the clinical indicator for considering a diagnosis of COPD. We have already discussed these things in our previous classes. So here we will discuss like what are the clinical indicator for considering a diagnosis of COPD. So they are telling consider the diagnosis of COPD and perform spirometry if any of these clinical indicators are present. So these indicators are not diagnostic, but they are like very sensitive markers, sensitive, and like we have to consider COPD. So first thing is dyspnea. Dyspnea, which is progressive over time, worse with exercise and persistent. Then comes recurrent wheeze is there. There is chronic cough, maybe intermittent or maybe unproductive. Then comes there is a history of recurrent lower respiratory tract infection, and history of risk factor is there like tobacco smoke, including popular local preparation. It could be anything like BD, cigarette, hookah, whatever. Then comes smoke from home cooking and heating fuel, occupational dust, vapors, fumes, gases, and other chemicals. Then host factors like genetic factor, developmental abnormalities, low birth weight, prematurity, and childhood respiratory infection, etc. Then they are telling what are the other cause of chronic cough. So either intrathoracic cause could be there or extrathoracic cause could be there. So what are the intrathoracic causes? So they are telling asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, and idiopathic cough. These are the intrathoracic causes. And what are the extrathoracic causes? So they are telling chronic allergic rhinitis, post-nasal drip syndrome, PNDS, UACS, upper airway cuff syndrome, GERD, and medications like ACE inhibitors. Then what are the differential diagnosis of COPD? So COPD is in COPD symptoms slowly progressive, and history of tobacco smoke or other risk factors are there. In asthma, there is like variable airflow obstruction. Symptoms vary widely from day to day. Symptoms worse at night and early morning. Allergy, rhinitis, and eczema is there. Often occur in children, and family history of asthma is there. And in congestive heart failure, CHF, there is like dilated heart and chest X-ray, pulmonary edema is there, and they are telling like PFT indicate volume restriction, and there is no airflow obstruction. So there is no, if there is no airflow obstruction, then we suspect congestive heart failure, and there is like dilated heart and chest X-ray. Then comes bronchiectasis. We know there is a large volume of purulent sputum production in the patients with bronchiectasis, and commonly it is associated with bacterial infection. Then there is like bronchial dilatation in chest X-ray and HRCT. So it is, we should consider it like it is because of bronchiectasis. In TB patients, it can occur in any age group, and like chest X-ray shows lung infiltrate, and microbiological confirmation should be there, and high local prevalence of tuberculosis should be there in that population. And they are telling, what about the obliterative bronchiolitis? It can occur in children, seen after lung or bone marrow transplantation. Very very important. It used to occur after lung and bone marrow transplantation. HRCT on expression so hypodense areas. Then comes diffuse pain bronchiolitis, predominantly seen in patients of Asian descent. Most patients are male and non-smokers. Almost all have chronic sinusitis. So all these patients used to have chronic sinusitis, and they are telling chest X-ray and HRCT shows diffuse small centrilobular nodular opacities, and hyperinflation is there in diffuse pain bronchiolitis. So they are telling these features tend to be characteristic of the respective diseases, but they are not mandatory. For example, a person who has never smoked may develop COPD, especially in LMIC, where other risk factors may be more important than cigarette smoking. So yeah, so they are not like they should be there. Like in most of the cases, they are there, but it is like they are not diagnostic. Then comes like what are the considerations while performing the spirometry? So yeah, they are telling like what is the preparation part. So they are telling that spirometers should produce like hard copies of a or have digital display of expiratory curve to permit detection of technical error, or have an automatic prompt to identify an unsatisfactory test and the reason for it. So like these are the preparation, like it should be a good spirometer. The supervisor of the test need training in optimal technique and quality performance. Obviously, maximal patient effort in performing the test is required to avoid underestimation of the values, and hence error in the diagnosis of the management. Yeah. After that, they are telling like in performing, then what should we like, what we should consider. So they are telling like spirometry should be performed following national or international recommendations. Very important. The expiratory volume traces should be smooth and free from irregularities. So there should not be irregularities. The pause between inspiration and expiration should be less than 1 second. Very, very important part. So pause between inspiration and expiration during spirometry should be less than 1 second in COPD patients. The recording should go on long for volume plateau to be reached, which may take more than 15 seconds. It can take in severe diseases. So very, very important. So it should go enough long. Both FVC and FEV1 should be the largest value obtained from any of three. So it should be the largest value of any of three technically satisfactory curves, and the FVC and FEV1 value in these three curves should vary by no more than 5% or 150 ml. So there should not be the difference of more than 5% or 150 ml. Okay. So yeah, and we should select the like largest value of all these three values. Then they are telling FEV1 upon FVC ratio should be taken from technically acceptable curve with the largest sum of FVC and FEV1. Then what about the bronchodilation? So about the bronchodilation, they are telling like possible dose protocol are like 400 microgram of short acting beta agonist. Like we should give 400 microgram of salbutamol and 160 microgram of short acting anticholinergic, or the two combined. We can give combinedly also. FEV1 should be measured after 10 to 15 minutes. Very, very important thing. Like we should measure after 10 to 15 minutes of giving short acting beta agonist, and after 30 to 45 minutes after short acting anticholinergic. Very, very important, because we used to remember this 10 to 15 minutes, but we do not remember this 30 to 45 minutes. And they are telling after a combination of both of the classes of the drug, also we should like perform after 30 to 45 minutes. Yeah. Then they are telling patients already on bronchodilator treatment in whom spirometry is requested for monitoring purpose do not need to stop their regular treatment for spirometry. Very, very important part, because we used to withheld it in the case of asthma patients. And about the evaluation, they are telling spirometry measurement are evaluated by comparison of the result with appropriate reference value based on age, height, sex, and race. The presence of bronchodilator FEV1 upon FVC ratio less than zero point 0.7 confirms the presence of non-fully reversible airflow obstruction. Very important. So this post bronchodilator, very important word. Like post, it's not be pre. It should be post bronchodilator FEV1 upon FVC, and it should be less than zero point 0.7, and it confirms the presence of non fully reversible airflow obstruction. Yeah. After that comes our next part, and which is like what is the spirometry trace, and like this is like normal spirometry curve, and this is the spirometry curve in airflow obstruction. In COPD patient, this is the curve. So here we can see like FEV1 has been reduced, and like FEV1 upon FVC ratio is like only 0.56. So it is like 56%. If it is like less than zero point 0.7, then we used to consider it COPD. So yeah, definitely it is a COPD case. Then they are telling about the role of spirometry in COPD patients. So yeah, we used to like use it for diagnosis, then assessment of severity of airflow obstruction, for prognosis. So we used to like grade it like either it is COPD gold grade 1, 2, 3, 4. Then for the follow-up assessment, like for therapeutic decisions, like for pharmacological in selected circumstances, where discrepancy is between spirometry and level of symptoms is there, or consider alternative diagnosis when symptoms are disproportionate for the degree of airflow obstruction, and for non pharmacological treatment like for interventional procedures, and for identification of rapid decline. So for these things, like we use spirometry in COPD patients. Then they are telling about the gold grading and severity of airflow obstruction in COPD patient, and it is based on the post bronchodilator FEV1. Very important. So there are gold 1, 2, 3, 4. Four grades are there. So first of all, we have to check post bronchodilator FEV1 upon FVC. If it is less than zero point 0.7, then we should like go for gold 1, 2, 3, 4. Then we have to check FEV1. If FEV1 is more than 80% or equal to 80% of the predicted, then we will suspect it is a mild or gold 1 category. If it is between like less than 80% to uh, equals to 50 or more than 50%, then it is moderate grade, and it is gold 2. Then comes like if it is less than 50% to equals to 30 or more than 30%, then it is like severe grade or gold 3. In gold 4, it is like very severe, and here FEV1 is less than 30% of the predicted. Then they are telling about the modified MRC dyspnea grade scale, MMRC scale of dyspnea. So they are telling what is like MMRC grade 0. So in MMRC grade 0, breathless occurs when patient is doing strenuous exercise. or anybody. What is MMRC grade 1? Grade 1 is like there is dyspnea on walking slightly uphill or like hurrying on the level of, means like if somebody is going uphill and he is having dyspnea, then this is MMRC grade 1. What is grade 2? So grade 2 is like person is walking slower than the people of same age group, or he has to stop for breath while walking at his or her own pace. Then comes MMRC grade 3. Here, like patient used to get dyspneic while walking for 100 meters or like for few minutes. And what is grade 4? Grade 4 is like person used to get breathless even while dressing or undressing or in resting condition. Now comes COPD assessment test. So this is CAT assessment. So here like they are telling there are like total 8 things we have to ask, and everything like can get like maximum 5 score or minimum 0 score. So like it is from 0 to highest score of 40, because every score can be given maximum 5, and there are total of 8 categories. So first thing is like about the cough. It's like patient had I never have cough, then we will give him like 0 score. If I have cough for all the times, then this is grade 5. Second is I have mucus in my chest at all. That I have no I have no mucus in my chest at all, then we will give it 0 score. If patient is telling my chest is completely full of mucus, then we will give him 5 score. If he is telling this is like second thing, chest mucus in the chest. Third thing is like chest tightness. So if my chest does not feel tight at all, then this is like 0 grading. If patient says my chest feels very tight, then this is like grade 5. Then comes like when I walk up hill or one flight of stairs, I am not breathless. Then this is grade 0. If patient is like breathless when I walk uphill or one flight of stairs, then I am very breathless. Then it is like grade 4. Then comes I am not limited doing any activities at home. Then this is grade 0. If patient is saying I am very limited doing activities at home, he is not able to do any activity at home, then we will give it 5 score. Then comes I am confident leaving my home despite my lung condition, then we will give it 0 score. If he is saying I am not confident at all leaving my home, then we will give it 5 score. Then comes about the sleep. I sleep soundly, then it is 0 grade. I don't sleep soundly because of my lung condition, then we will give it 5 score. I have lot of energy, 0 score. I have no energy at all, then we will give it 5 score. So like maximum, like for every condition we can give maximum 5 score, and there are total 8 conditions, so maximum score are like 40. So 0 to 40 is the scoring of this. And like we think like if score is more than 10, we suspect COPD. Yeah, then comes gold ABE assessment tool. First of all, we have to like spirometrically confirm the diagnosis. For that, we have to check post bronchodilator FEV1 upon FVC ratio. If it is less than zero point 0.7, then we should proceed further. Here we will assess the airflow obstruction according to gold grade 1 to 4. If it is like more than equal or more than 80%, or it is 50 to 79, or it is 30 to 49, it is less than 30. According to that, we will grade 1, 2, 3, 4. Then we used to assess symptoms and risk of exacerbation. So they are telling like there are total 3 categories: category A, B, and E. We have removed category C and D, and they are combined, and together we will tell them category E. So yeah, so they are telling if there is more than or equal to two moderate exacerbation history, or more than or equals to one leading to hospitalization, then we will simply call it category E. It will not like depend on MMRC or CAT scoring. We will call it category E. Yeah, for like classification of category A and B, we will use MMRC grade. So for both of the classes, there should be one or zero moderate exacerbation, and there should be no history of hospitalization. Then we will check MMRC grading. If MMRC grading is like between 0 to 1 and CAT scoring is less than 10, then we will suspect is like this is category A. If CAT score is more than 10 and MMRC grading is more than 2 or equals to 2, then we will tell it this is category B. Okay. Then comes use of CT in stable COPD patients. So yeah, this is actually new thing which has been added this time only. Yeah, let's start. So they are telling to it is used to differential diagnosis. So they are telling like frequent exacerbation with the excessive cough with sputum production is there, raising concern of bronchiectasis or atypical infection is there, then we should perform the CT. Symptoms out of proportion to the disease severity based on the lung function testing. Like lung function testing is not showing that much obstructive airway defect, but symptoms are out of proportion of that. So we will suspect like yeah, it should be some other condition. Then lung volume reduction is there. Like they are telling endobronchial valve therapy may be a therapeutic option for the patient if they demonstrate post bronchodilator FEV1 between 15 to 45%, and evidence of hyperinflation is there, and they are telling lung volume reduction surgery may be therapeutic option for patient with hyperinflation, severe upper lobe predominant emphysema, and low exercise capacity after pulmonary rehabilitation. So for these cases, we used to perform CT and then do lung volume reduction surgeries. Then they are telling about the lung cancer screening. For lung cancer screening, like annual dose CT scan is recommended for lung screening in patients with COPD due to smoking. Very, very important. Like COPD due to smoking, in those patients only we used to perform annual low dose CT scan according to recommendation for general population. Then they are telling, yeah, what are the brief strategies to help the patient willing to quit smoking. So they are telling that they are for age. First thing is like ask. We have to ask the patient. They are telling systematically identify all tobacco users at every visit. Implement an office-wide system that ensure that every patient at every clinic visit tobacco use status is queried and documented. So we should ask every time patient like either he used to smoke or not, very very, and document it. Then after asking we should like advise him. So they are telling strongly urge all tobacco users to quit. Tell them that they should quit it in a clear, strong and personalized manner. Urge every tobacco user to quit. After advising we should assess. So they are telling like determine willingness and rationale of the patient desire to make a attempt. Either he is willing to quit the smoking. After assessing, they are telling we should assist. So add the patient in quitting. They are telling help the patient with a quit plan, provide practical counseling, provide intra-treatment social support, help the patient obtain extra treatment social support, recommend use of approved pharmacotherapy except in special circumstances, provide supplementary materials. After that we have to arrange. They are telling like schedule follow-up contact either in person or via telephone. So yeah, these are the five things like they are telling. We should ask the patient, then we should advise him, then we should assess him, then we should assist him. After that we should arrange the phone calls and like follow-up schedule. After that they are telling about the vaccination for stable COPD patients. They are telling like influenza vaccination is recommended in patients with COPD. Obviously, they are telling COVID-19 vaccination is also recommended, and they are telling like CDC recommend one dose of 20 valent pneumococcal vaccine or one dose of 15 valent, any of both of them, like either 20 valent or 50 valent, followed by 23 valent pneumococcal vaccination, polysaccharide vaccine in people with COPD. And they are telling like pneumococcal vaccination has been shown to reduce the incidence of community acquired pneumonia and exacerbation in patients with COPD, and it has been proved by evidence B, which is like yeah, okay. Then they are telling there is like new guidelines. They are telling like CDC recommended vaccination to protect against pertussis. So for that we should give DTaP vaccine for whooping cough for patients who have not vaccinated in adolescence life. Very important. So who have not taken pertussis vaccination in adolescence life, then we have to give them DTaP vaccine and zoster vaccine to protect against shingles for patients of COPD who are of more than 50 years of age. After that comes like commonly used maintenance medication in COPD patients. So yeah, we should discuss it in detail. So they are telling that there are like beta 2 agonists. So what are the SABA? So they are telling like phenoterol, leva, albuterol, and salbutamol and terbutaline. So salbutamol is also known as albuterol. So albuterol, levoalbuterol, phenoterol, and terbutaline. These are like beta short-acting beta agonist, and their duration of action is like 4 to 6 hours, like in most of the cases. Then comes long-acting beta two agonist. These are R-formoterol, formoterol, indacaterol, oladeterol, and salmeterol. Then comes and these used to act around like 12 to 24 hours. Then comes anticholinergics. First is short-acting uh, muscarinic antagonists. These are ipratropium bromide and oxytropium bromide, and these used to act around like 6 to 9 hours. Then comes LAMA, long-acting muscarinic antagonist. These are aclidinium bromide, glycopyrronium bromide, tiotropium, omeclidinium, glycopyrrolate, then revifenacin, and these used to act around like 12 to 24 hours. And here they are telling like tiotropium is available in all three combinations like DPI, SMI, and MDI. Then they are telling about the combination of short-acting beta agonist and anticholinergic in one device, like SAVA plus SAMA, like phenoterol ipratropium combination and salbutamol and ipratropium combination. Then they are telling about the combination of LABA and LAMA. So this is like formoterol aclidinium combination, formoterol glycopyrronium combination, indacaterol glycopyrronium combination, vilanterol omeclidinium combination, and oladeterol tiotropium combination. So they are telling vilanterol omeclidinium combination used to act for 24 hours. Like we should use it once only for whole day. And oladeterol tiotropium combination is also a once used combination. So it used to act for 24 hours. Very, very important. So these are like newer combinations. Then comes methyl xanthines. These are like aminophylline and theophylline. And these are variable, these have variable duration of action and these used to act for 24 hours. And available, aminophylline is available in solution while theophylline is available in pill form. Then comes combination of LABA plus corticosteroid in one device like formoterol plus beclomethasone, formoterol plus budesonide, formoterol plus mometasone, salmeterol plus fluticasone. So these used to act for 12 hours. And there is a new combination of blanterol and fluticasone. Blanterol and fluticasone is available in DPI form and it used to act for 24 hours. Then comes triple combination in one device. So they are telling like fluticasone, omeclidinium plus blanterol. It used to act for 24 hours. It is available in DPI form. Then comes beclomethasone, formoterol, glycopyrronium. It is available in MDI DPI and it used to act for 12 hours. Then comes budesonide, formoterol, glycopyrrolate combination and it used to act for 12 hours and available in MDI format. Then comes phosphodiesterase 4 inhibitors. This is like roflumilast, very very important. And roflumilast is available in the pill form, and it used to act for 24 hours. Then comes mucolytic agents like erdocystine, carbocysteine, and acetylcysteine, and these all are available in pill form, and they used to act for 12 hours. Yeah. After that, they are telling about the bronchodilators in stable COPD patients. So they are telling like, yeah, so they are telling about the inhaled bronchodilator. So inhaled bronchodilator in COPD are central to symptom management and commonly given in regular basis to prevent or reduce the symptoms. Yeah. So like inhaled bronchodilator are treatment of choice. Regular and as needed use of SABA and SAMA improves FEV1 and symptoms. Obviously, combination of SABA and SAMA are superior to either medication alone. Obviously, LABA and LAMA significantly improve the lung function, dyspnea, health status, and reduce exacerbation rates. So LABA, like long-acting medications, are obviously improve the lung function and dyspnea and health status and reduce exacerbation rate. Then they are telling how the LAMA has greater effect on exacerbation reduction compared with LABA. So like they are telling, muscarinic antagonists are like better than beta agonist. Long-acting muscarinic antagonists are better than long-acting beta agonist. After that, they are telling like combination of lava plus lama increases FEV1 and reduce the symptoms. Obviously, combination treatment with lava lama reduces exacerbation compared to monotherapy. Obviously, then they are telling tiotropium improves the effectiveness of pulmonary rehabilitation and increase exercise performance. Theophylline exerts a small bronchodilator effect in stable COPD, and that is associated with modest symptomatic benefit. And this is proven by evidence D. So this is like not a good drug to be given in COPD patient. And single inhaler therapy may be more convenient and effective than multiple inhalers. Obviously, like it will be more convenient to the patient to take like single inhaler rather than taking multiple inhalers. Then comes like anti-inflammatory therapy. So yeah, we should discuss this thing also in detail. So yeah, they are telling like what about the inhaled corticosteroid? So they are telling an ICS combined with LABA is more effective than individual component in improving lung function, obviously, and health status and reducing exacerbation in patients with exacerbation in moderate to very severe COPD. So ICS we should give in moderate to severe COPD patients. So they are telling regular treatment with ICS increases the risk of pneumonia, especially in those with severe disease. Obviously, lower blood and sputum eosinophils are associated with greater presence of proteobacteria like Haemophilus, and it used to increase the risk of bacterial infection and pneumonia. So yeah, so they are telling like independent of ICS use, there is evidence that blood eosinophilic count less than 2% increases the risk of pneumonia. So if blood eosinophilic count is like less than 2% or less than 300, then there are chances of pneumonia if we are giving them this inhaled. We should, so that's why we should not give them inhaled corticosteroid. Triple inhaled therapy of LAMA ICS improve the lung function, symptoms, and health status and reduce exacerbation compared to LAVA plus ICS. Um, or LAMA immunotherapy. So like triple combination is better than every other combination. Recent data suggests that beneficial effect of triple inhaled therapy versus fixed dose LAVA plus LAMA combination of mortality in symptomatic COPD patient with history of frequent severe exacerbations. So they are telling like with the triple inhaled therapy, like there is decreased chances of mortality. And single inhaler therapy may be more convenient and effective than multiple. We have already discussed it. Then they are talking about the oral glucocorticoids. So they are telling long-term use of oral glucocorticoids has numerous side effects. So because of them, there is like no evidence of benefit. What about the phosphodiesterase 4 inhibitors? So they are telling in patients with chronic bronchitis, very very important, with severe to very severe COPD means FEV1 less than 50 and history of exacerbation is there, then we should give them phosphodiesterase 4 inhibitors. What is that? That is like roflumilast. If phosphodiesterase 4 inhibitor improve lung function, reduces moderate to severe exacerbations, and they are telling it improve lung function, decreases exacerbation in patients with who are on fixed dose lava plus ICS combinations. Like already they are taking lava plus ICS combinations. So for those patients, and they are like having chronic bronchitis, having severe to very severe COPD, and history of exacerbation is there, then like we should give them a trial of roflumilast. Then comes antibiotics. So they are telling like long-term azithromycin and erythromycin reduces exacerbation over 1 year. So like yeah, long-term azithromycin should be given. Treatment with azithromycin is associated with increased incidence of bacterial resistance. So we should remind this thing. We should like think about it before giving long-term azithromycin, and uh, it can lead to hearing test impairment also. What about the mucoregulator and antioxidants? So they are telling regular treatment with mucolytic such as aldocysteine, carbocysteine, and N-acetylcysteine reduces the risk of exacerbation in selected population. So yeah, they used to reduce exacerbation in selected population only. What about the other anti-inflammatory agents? So they are telling like simvastatin does not prevent exacerbation in COPD patient at increased risk of exacerbation and without indication for statin therapy. So yeah, however, observational studies suggest that statins may have positive effect on some outcomes in patients with COPD who receive them for cardiovascular and metabolic indication. If patient is having cardiovascular and metabolic indication for use of sim, simvastatin, then we should give them this thing, simvastatin, and it can reduce the COPD exacerbations. Then they are telling like modifiers have not been tested adequately in COPD patients. So like there is no proper data available. What about the factors to consider when initiating ICS treatment? So they are telling factor to consider when adding ICS to long acting, like patient is already taking this like long acting bronchodilator treatment. Then when we should add or when we should not add this inhaled corticosteroid. So they are telling what are the factors which strongly favor the use. So they are telling there is history of hospitalization for exacerbation of COPD is there. There are like two or more than two moderate exacerbation of COPD per year. Blood eosinophil count is like more than 300 cells per microliter, and history of asthma is there. Then we should like strongly use ICS. Very very important. Then what are the things which only favor these things like not strongly favor. So like one moderate exacerbation of COPD per year, or like blood eosinophil count less like less than 300 but like more than 100, like 100 to 300 is there, then we can give them like ICS. But if there is history of repeated pneumonia infection and blood eosinophil count is like it is like less than 100 and history of mycobacterial infection is there, then we should not give them inhaled corticosteroid. Very very important. Then they are telling out the evidence supporting a reduction in mortality with pharmacotherapy and non-pharmacotherapy in COPD patients. Very, very important. So, like this is a new thing which has been added this time only in gold guideline. So, yeah, they are telling like triple compared to dual long-acting bronchodilators used to like reduce the mortality, or and like it has been proven by randomized controlled trials. But like it is in symptomatic patients with a history of frequent or severe exacerbation. If in these patients we are giving like triple combinations, then it used to decrease the mortality. What about the non-pharmacological therapy? They are telling like smoking cessation in asymptomatic or mildly symptomatic patients used to decrease the mortality. Pulmonary rehabilitation in hospitalized patient for exacerbation of COPD like during or less than 4 weeks post discharge. If we are doing pulmonary rehabilitation, then like it used to reduce the mortality. If patient okay, so they are telling if PaO2 is less than 55 or less than 60 with core pulmonary or secondary polycythemia is there, then long term oxygen therapy used to reduce the mortality. Very very important. They are telling if there is stable COPD patient with marked hypercapnia is there, then then they are telling non-invasive positive pressure ventilation like NIV is NIV used to reduce the mortality. Then if upper lobe emphysema and lower exercise capacity is there, then lung volume reduction surgery used to reduce the mortality. So these are like if these characteristics are present, then if we are taking these interventions, then these used to reduce the mortality. So yeah, this is also a very important thing which has been proven. Yeah, now they are telling about the other pharmacological treatment. So alpha 1 antitrypsin or augmentation therapy we should give them, like if patient is having alpha 1 antitrypsin deficiency, then we should give them intravenous augmentation therapy, and it may slow down the progression of emphysema, and it has been supported by evidence B. Antitussive, there is no conclusive evidence of beneficial role of antitussive. And what about the vasodilators? They are telling vasodilators do not improve outcome and it may worsen the oxygenation. Very, very important. So we should not give vasodilator at all, like calcium channel blocker. What about the pulmonary rehabilitation and self-management and integrative care of COPD? So they are telling about the pulmonary rehabilitation. Pulmonary rehabilitation improve dyspnea, health status, and exercise tolerance in stable patients. Then they are saying like pulmonary rehabilitation reduce hospitalization among patients who have had a recent exacerbation, means less than 4 weeks from prior hospitalization. Means like if within like 4 weeks patient had another exacerbation, in those patients if we are doing like pulmonary rehabilitation, then it used to reduce the hospitalization. Pulmonary rehabilitation lead to a reduction in symptoms of anxiety and depression. What about the education and self-management? They are telling like education alone has not been shown to be effective. Self-management intervention with communication with a healthcare professional improve the health status and decrease the hospitalization and emergency department visits. What about the integrated care programs? So they are telling integrated care and telehealth have no demonstrated benefit at this time. Okay. After that, they are talking about the palliative care and end of life hospital care in COPD. So they are telling like opiates, neuromuscular electric stimulations, oxygen and fans blowing air on the face can relieve breathlessness. So yeah, like fan who are blowing air on their face can relieve breathlessness. In malnourished patient, nutritional supplementation may improve respiratory muscle strength and overall health status. So we should also give them more nutritional supplements. Yeah. After that, they are telling fatigue can be improved by self-management, education, pulmonary rehabilitation, nutrition support, and mind-body intervention. Okay. After that, they are talking about the oxygen therapy and ventilator support in stable COPD patient. So yeah, in whom we should give them oxygen therapy. So they are telling like long-term administration of oxygen increases survival in patient with severe chronic resting arterial hypoxemia, like PaO2 is less than 40, then we should give them oxygen therapy. In patient with stable COPD and moderate resting or exercise induced arterial desaturation is there, or prescription of long term oxygen does not lengthen time of to death or first hospitalization or provide sustained benefit in the health status, lung function, and 6 minute walk test. So they are telling like it does not like increase the duration to which like a patient used to get die. So they are telling resting oxygenation at sea level does not exclude the development of severe hypoxemia with traveling by air. What about the ventilator support? So non invasive positive pressure ventilation may improve hospitalization free survival in selected patient after recent hospitalization, particularly in those with pronounced daytime persistent hypercapnia, means PaCO2 more than 53 mmHg. In those cases like non-invasive NIV, we should use NIV. Okay, yeah, this is like very important slide, and like it has been added first time in gold guideline. So yeah, what it used to say, this is like overview of current and proposed surgical and bronchoscopic interventions for the patients with COPD. Very, very important. So like these are the symptoms. If patient is having chronic mucus production, then we should suspect like it is due to chronic bronchitis. And what surgical and bronchoscopic intervention required? So they are telling nitrogen cryospray or rheoplasty. Nitrogen cryospray and rheoplasty are beneficial for chronic bronchitis patient who is having chronic mucus production. If patient is having like exacerbations, then we should suspect acute or chronic bronchitis, bulla, emphysema, or tracheomalacia. And for these patients, do we should do targeted lung denervation. We should denervate it. If patient is having dyspnea, then we should suspect bulla, emphysema, or tracheobronchomalacia. And for these cases, we should do giant bullectomy, large airway stenting, EBB, coiling, thermal vapor ablation, lung sealant, lung volume reduction surgeries, lung transplantation. So these are like surgical and bronchoscopic interventions which are required uh, for like different conditions. After that, they are talking about the management of the COPD. Very important. So they are talking like first we have to diagnose the COPD. So for that symptoms, risk factors, spirometry, these things we have to do. Then we should do initial assessment. Like we should like perform spirometry and check like FEV1. So they are telling we should, according to FEV1, we should classify patient from gold 1 to 4. Then we should assess the symptom like according to that we should check like CAT scoring and MMRC grading and exacerbation history. We should check according to that we should classify like either it is gold A, B or E. Then check the smoking status, alpha 1 antitrypsin level and comorbidities. After that, we should do initial management like smoking cessation, vaccination, active lifestyle and exercise, initial pharmacotherapy we should do give, and self-management education like risk factor management, inhaler technique, breathlessness, written action plan, and manage comorbidities. After that, we should review the patient. During review, we should like check the CAT and MMRC grading, exacerbation status, smoking status, exposure to other risk factor, inhaler technique, physical activity and exercise, need for pulmonary rehabilitation is there or not, self-management skill like breathlessness, written action plan is there or not, need for oxygen and IV lung volume reduction or palliative approach or vaccination, about the management of comorbidities and spirometry. At least annually we should do spirometry, very important. Annually we should do a spirometry. After that, after reviewing, we should adjust these things like pharmacotherapy and non-pharmacological therapy. After adjusting, we should again review the patient and like follow this loop again and again. Now they are talking about the goals of treatment for stable COPD patients. So they are telling like to reduce the symptoms, we should relieve the symptom, improve the exercise tolerance, and improve health status of the patient. These used to reduce the symptom, prevent disease progression, prevent treat exacerbation, and reduce mortality. These used to reduce the risk. After that, they are talking like treating tobacco use and dependence, a clinical practical practice guide and major findings and recommendations. So yeah, we should discuss it in our detail in the detail. Yeah. So they are telling like tobacco dependence is a chronic condition that warrant repeated treatment until long-term permanent abstinence is achieved. So yeah, if patient is taking tobacco, doing tobacco smoking, then it needs long-term treatment. Then they are telling effective treatment for tobacco dependence exists, and all tobacco users should be offered these treatments. So yeah, these dependence treatment are available. So they are telling clinician and healthcare delivery system must operationalize the consistent identification, documentation, and treatment of every tobacco user at every visit. Brief smoking cessation counseling is effective, and every tobacco user should be offered such advice at every contact with healthcare provider. There is a strong dose response relation between the intensity of tobacco dependence and counseling and its effectiveness. Three types of counseling have been found to be especially effective. First is practical counseling. Second is like social support of family and friend as a part of treatment, and social support arranged outside of the treatment. They are telling first line pharmacotherapy for tobacco dependence are vernicillin, very very important. Bupropion, sustained release. Nicotine gums, nicotine inhaler, nicotine nasal spray, nicotine patch. So yeah, nicotine related things are there. Vernicillin is there and bupropion sustained release tablet is there. So these are effective and at least one of these medications should be prescribed in the absence of contraindication. If these are not contraindicated, then we should give one of these medications. Very, very important. After that, they are talking like financial incentive programs for smoking cessation may facilitate smoking cessation. We should give them like financial benefit also. Tobacco dependence treatment are cost effective interventions.
Yeah, they are telling that we should identify and reduce risk factor exposure. So they are telling smoking cessation intervention should be actively pursued in all people with COPD. Efficient ventilation, non-polluting cooking stoves, and similar intervention should be recommended. And clinicians should advise patient to avoid continued exposure to potential irritant if possible. Then they are telling what are the key points for inhalation of drug. So they are telling when a treatment is given by the inhaled route, the importance of education and training in inhaler device technique cannot be overemphasized. So they are telling the choice of inhaler device has to be individually tailored and will depend on access, on cost, prescriber, and most importantly, the patient's ability and preference. So they are telling like choice of inhaler device used to depend on a lot of factors. So like most important factor is like patient's ability and preference, like what he wants to use. So that is like most important factor in choosing the inhaler device. Then they are telling it is essential to provide instructions and demonstrate the proper inhalation. Like we should demonstrate the patient like how to use the inhalation technique when prescribing a device to ensure that inhaler technique is adequate and recheck at each visit that patient continue to use with inhaler correctly. Inhaler technique and adherence to the therapy should be assessed before concluding that the current therapy is insufficient. So like before like proving that patient is not responding, before that we have to like assess like either he is using properly or not. After that, what are the basic principle to for appropriate inhalation device choice? So yeah, they are telling like ability of drug. Like there is one factor that availability of the drug in the device, which drug is available. Then patient's belief satisfaction with current and previous device and preference need to be assessed and considered. The number of different devices type should be minimized for each patient and ideally only one device. Finally, we should like choose one device for particular patient. Then they are telling device types should not be switched in absence of clinical justification nor without proper information, education, and medical follow-up. Like before changing the medical device, we have to like there should be a clinical justification for that, and like we should like properly inform, educate the patient, and follow up that patient. Then they are telling like shared decision making is the most appropriate strategy for inhalation device choice. So like it should be shared communication between patient and clinician. Then patient's cognition, dexterity, and strength must be taken into account. Patient's ability to perform correct specific inhalation maneuver for the device must be assessed. So they are telling if dry powder inhaler are appropriate only if patient can make a forceful and deep inhalation. If patient can make forceful and deep inhalation only, then we should prescribe DPI. Check visually that patient can inhale forcefully through the device. If there is doubt, assess objectively or choose alternate device. If patient is not able to deeply inhale, forcefully inhale, then we should not use DPI. Then we will come to MDI, metered dose inhaler, and to the latter lesser extent, soft mist inhaler require coordination between device triggering an inhalation, and patients need to able to perform a slow and deep inhalation. Check visually that the patient can inhale slowly and deeply. So for this MDI, we should like check like patient can inhale slowly and deeply from the device. If there is doubt, consider adding a spacer VSC or choose alternate device. If there is doubt in this, like if patient is not able to use MDI, then we should add a spacer. For patient unable to use MDI with or without spacer or VSC, SMI or DPI or nebulizers should be considered. Then they are telling other factor to be considered like size, portability, and cost of the inhaler. Then a smart inhaler can be used if there is issue with adherence and persistence or inhalation technique. Then we can use smart inhaler techniques, which used to calculate like how many times patient has taken like inhaler, have used inhaler. Then like they are telling physicians should prescribe only device they know how to use. If patient know, then like if what like patient know, clinical clinician should advise only that device to the patient. Then they are telling key point for use of bronchodilator. LAVA and LAMA are preferred over short-acting agent except for the patient with occasional dyspnea. Obviously, and occasionally, if patient is having only occasional dyspnea, then we should prescribe SABA. And for immediate relief of symptoms in patient already on long-acting bronchodilator for maintenance therapy, like in acute exacerbation of COPD, initially we used to give SABA. Then they are telling when initiating treatment with long-acting bronchodilator, the preferred choice is the combination of LABA and LAMA. In patient with persistent dyspnea on a single long-acting bronchodilator, it should be escalated to the combination, and combination should be like LABA and LAMA. Then they are telling inhaled bronchodilator are recommended over oral. So like inhaled are better than oral. After that, they are telling theophylline is not recommended unless other long-acting treatment bronchodilator are unavailable or unaffordable. Only in those conditions we can advise theophylline, otherwise we will not give theophylline. Then about like anti-inflammatory agent, they are telling like long-term monotherapy with ICS is not recommended. We do not encourage the use of LAVA plus ICS combination in COPD. If there is an indication of for use of ICS, then we can give LAVA plus LAMA plus ICS, which are superior to LAVA plus ICS, and is therefore the preferred choice. LAVA plus LAMA plus ICS is preferred choice. This combination can be given as single or multiple inhaler therapy. In patient with COPD having feature of asthma, treatment should always contain inhaled corticosteroid. Then they are telling in patient with severe to very severe airflow limitation, chronic bronchitis, exacerbation, the addition of phosphodiesterase 4 inhibitor to the treatment with long-acting bronchodilator with or without inhaled corticosteroid can be considered. Then they are telling preferentially, but not only in former smokers with exacerbation despite appropriate therapy, macrolide in particular, azithromycin we can use, and they should be used only for 5 days. And they are telling statin therapy or beta blockers are not recommended for the prevention of exacerbation. Key point for the use of other pharmacological treatments. So they are telling like we should give alpha 1 antitrypsin augmentation therapy in patients with severe hereditary alpha 1 antitrypsin deficiency and established emphysema. Antitussive agents cannot be recommended. Drugs approved for primary pulmonary hypertension are not recommended. Then they are telling low dose, long acting oral and parenteral opioid may be considered. So like we can give opioids which are low dose and long acting oral and parenteral for treating dyspnea in COPD patients with severe disease. Yeah, after that they are telling initial pharmacological treatment according to the category. So they are telling in group A, we used to give a bronchodilator. It could be SABA, SAMA, LAVA, whatever. In group B, we used to give combination of LABA plus LAMA, and they are telling single inhaler therapy may be more convenient and effective than multiple inhaler. So like here, if we are giving combination, then we should give combination in a single device. So LABA plus LAMA combinations we used to give in group B. In group E also we used to give LABA plus LAMA. But if blood eosinophil count is more than 300, then we can start inhaled corticosteroid, like triple therapy we can give. After they are talking about the management cycle, like there is a cycle that we have to review. In review, we used to like check symptoms, dyspnea and exacerbation. After that, we used to assess like inhaler technique are correct or not, then adherence. Then we should check like non pharmacological approaches like pulmonary rehabilitation and self management education. After that, if there is problem in these things, then we should adjust. So either we should escalate or de-escalate the therapies and switch inhaler device or molecules. Then they are talking about the follow-up of the pharmacological treatment. So they are telling we should, like, if patient is responding to initial treatment, then we should maintain it. We should do nothing and we should continue the treatment. They are telling if it is not like going okay, then we should check adherence, inhaler technique, initially these things. Then like we should check the predominant symptom, like either dyspnea is prominent or like exacerbation is prominent. If dyspnea is like main thing, then like we should give them lava plus lama. And after that they are telling lava and lama, then they are telling uh, we should give them like single inhaler device. Initially we should give lava or lama, then we should give them combinations, and they are telling considering switching inhaler device or molecule, then we can change these inhaler devices and molecules also, implement or escalate non-pharmacological treatment and investigate other causes of dyspnea could be there, so we should investigate for that also. If exacerbations are prominent, then they are telling lava and lama we should give. If blood eosinophil count is more than 300, then we should add inhaled corticosteroids also. And they are telling if blood eosinophil count is less than 300, then we should continue lava plus lama combinations. And they are telling if blood eosinophil count is more than 100, then we can give inhaled corticosteroid. If blood eosinophil count is less than 100, then if FEV1 is less than 50%, chronic bronchitis is there, then we should add roflumilast. And they are telling if patient is former smoker, like previously he was a smoker but now he is not a smoker, then we can give azithromycin also. They are telling consider de-escalation of ICS, like we should remove the ICS if pneumonia or other considerable side effect of inhaled corticosteroid are there. In case of blood eosinophil count more than 300 cells per microliter, de-escalation is more likely to be associated with development of exacerbations. So they are telling like it can lead to exacerbations. After that, they are talking about the non-pharmacological management of COPD. So they are telling in group A, we should like do smoking cessation and recommend the physical activity, and depending according to the local guideline, flu vaccination, pneumococcal, pertussis, COVID-19 and single vaccinations should be given. Vaccination we know like it used to be given like for more than 50 year of age of the patients, and pertussis for those who have not like taken vaccination in their adolescence life, then we should give them DTaP vaccine. After that, they are talking about the B and E group. So they are in them like essential is like we should do smoking cessation, and pulmonary rehabilitation is also part of essential non-pharmacological treatment, very important. After that, we should recommend them physical activity and these all the vaccines. Then follow up of the non-pharmacological treatment. So they are telling if initial treatment is appropriate, then we should maintain it, and like they are telling we should offer them flu vaccination every year and other recommended vaccination according to guidelines, self-management education, assessment of behavioral risk factors such as smoking cessation if applicable and environmental exposures, and ensure maintenance of exercise program and physical activity, adequate sleep and healthy diet. If response is not there, then consider the predominant treatable trait to target. So, like if dyspnea is prominent or exacerbation is prominent. So, they are telling if dyspnea is prominent, then self management education, written plan we should give them with integrated self management regarding breathlessness, energy conservation technique, and stress management strategies. After that, they are telling like we should do pulmonary rehabilitation program or maintenance exercise program post pulmonary rehabilitation. If exacerbations are prominent, then self management education written action plan should be there. That is personalized with respect to avoidance of aggravating factor, how to monitor or manage worsening of symptom, and contact information in event of exacerbation. Then they are telling all patients with advanced COPD should be considered for end life palliative care support. So all patients with advanced COPD should be considered for end life and palliative care support to optimize symptom control and allow patients and their family to make informed choice about future management. Then they are talking about the prescription of supplemental oxygen to COPD patient. If arterial hypoxemia like PaO2 less than 55 mmHg and SaO2 is less than 88%, मतलब saturation is like less than 88% and arterial oxygen is less than 55 mmHg, or arterial oxygen is between 55 to 60, but there is right heart failure or erythrocytosis is there, then we will call it arterial hypoxemia. Then we should prescribe supplemental oxygen and titrate it and keep it around 90. Like it should be either 90 or more than 90. And recheck it in like 60 to 90 days to assess if supplemental oxygen is still indicated, if prescribed supplemental oxygen is effective or not. After that, they are telling like surgical and interventional therapies in advanced emphysema. So emphysema predominant phenotype with hyperinflation is there. Then if bulla is large, then we should do bulloectomy. If bulla is not large, then we should check like if it is heterogeneous emphysema or not. If they are telling if it is like that, then we should check like collateral ventilation is there or not, and fissure integrity is there or not. If there is no collateral ventilation and fissure integrity is present, then we should do endoscopic lung volume reduction. Very, very important. So endoscopic lung volume reduction is done if there is no collateral ventilation and fissure integrity is present. They are telling if collateral ventilation is present and fissure integrity is absent, then also we can do like this these things like endoscopic lung volume reduction surgery. They are telling, but we can't do EBV. Yeah, endobronchial valve we can't use in this condition. Like endobronchial valve can be used only in case of collateral ventilation is absent. Then they are telling if it was there, if it is because of heterogeneous emphysema. If there is homogeneous emphysema, then also we should check these things only. Either if collateral ventilation is present or not and fissure integrity is there. If collateral ventilation is absent and fissure integrity is present, then we can do endobronchial valve. We can use endobronchial valve. Otherwise, if collateral ventilation is present and like fissure integrity is absent, then we cannot use endobronchial valve. They are telling not candidate if like we can't do bulloectomy or endoscopic lung volume reduction or like lung volume reduction surgery, then we should do lung transplantation. So yeah, this is in advanced emphysema. Then comes like key point for use of non-pharmacological treatment. Like we have already discussed these all things. Then like we should discuss like one thing that is like more very important. So they are talking about the intervention bronchoscopy and surgery. So yeah, we are discussing like this part. We will discuss this part. So they are telling like in patient with very severe COPD, means progressive disease is there and body score of 7 to 10 and not candidate for lung volume reduction, then lung transplant may be considered for referral with at least one of the following. So if there is only one thing present out of these, then we should consider that patient for lung transplantation. So what are like these? There are three things. First thing is like History of hospitalization for exacerbation associated with acute hypercapnia means PaCO2 more than 50 mmHg is there, was there. So this is like history of hospitalization for exacerbation. Second thing is pulmonary hypertension and or corpulmonal despite oxygen therapy. This was like second thing, pulmonary hypertension. Third thing is like FEV1 is less than 20, like very severe, and either DLCO less than 20% or homogeneous distribution of emphysema is there, then we should like consider for lung transplantation. But it is supported by only evidence C. Yeah. So after that comes like confounder of or contributor to be considered in patient presenting with suspected COPD. So they are telling like what are the most frequent and what are the less frequent things. So most frequent things are like pneumonia. For that we should do chest X-ray. Second thing is pulmonary embolism. For that we should do clinical probability assessment by checking hemoptysis, surgery, fracture history of cancer, DVT. We should do D-dimer, CT angiography for pulmonary embolism, heart failure. For heart failure, we should do chest X-ray, and then NT-proBNP, BNP level echocardiography. And they are telling less frequent things are like pneumothorax and pleural effusion. For pneumothorax pleural effusion, we should do like USG and chest X-ray, and for MI we should do TROP-I and ECG. After that, they are talking like about the diagnosis and the assessment. So they are telling like complete and thorough clinical assessment for evidence of COPD and potential respiratory and non-respiratory concomitant diseases, including consideration of alternative cause of patient symptom and sign. Primarily pneumonia, heart failure or pulmonary embolism could be there. So they are telling we should assess the symptom severity of dyspnea that can be determined by the using of VS and documentation of the presence of cough. Then we should check the sign like tachypnea, tachycardia, sputum volume and color. We should check like is there respiratory distress or not. If like patient is using accessory muscles, then we can think like it is due to respiratory distress. Then evaluate severity by using appropriate additional investigations such as pulse oximetry, lab assessment, CRP, ABG, and establish the cause of event. Either it is because of viral, bacterial, or environmental. Then they are talking about the classification of severity of COPD exacerbations. So they are telling that COPD patient with suspected exacerbations comes to you. Then like we should go for two things. They are telling like confirm ECOPD diagnosis and episode severity. And they are telling consider differential diagnosis also. What could be differential diagnosis? We know heart failure, pneumonia, pulmonary embolism. For that we should do appropriate testing and treatment. And they are telling like confirm ECOPD diagnosis and episode severity on the basis of like previous episode. So they are telling like we should check the severity of exacerbation. So mild exacerbation we will call it when like variable threshold to determine the severity. So they are telling like if dyspnea is less than 5, dyspnea VAS is less than 5, respiratory rate is less than 24 breath per minute, heart rate is less than 95 beat per minute, resting saturation of oxygen is more than 90%, breathing ambient air or patient's usual oxygen prescription, and change is less than 3%, and CRP is less than 10 milligram per ml if obtained. Then they are talking about the moderate. So for moderate, they are telling it should meet 3 of these all 5. So what are like those 5 criteria? So they are telling like dyspnea VAS should be more than 5 or equals to 5. Respiratory rate should be more than 24. Heart rate should be more than 95. Oxygen saturation should be less than 92%. And like change should be more than 3%, and CRP should be more than 10 milligram per liter. If obtained, ABG may show hypoxemia, means PaO2 should be less than 60 mmHg, and hypercapnia means PaCO2 more than 45 mmHg. But there is no acidosis in moderate exacerbation. Then comes severe exacerbation. In severe, they are telling dyspnea, respiratory rate, saturation, CRP, all should be like moderate. What was moderate? So dyspnea like VS, dyspnea VS should be more than 5, respiratory rate more than 24 or equals to 24, heart rate should be like equals to or more than 95, CRP equals to or more than 10 milligram per liter. And ABG shows hypercapnia and acidosis, means PaCO2 more than 45 mmHg and pH less than 7.35. Then they are talking about the determine the etiology. So like to confirm the what could be like infectious cause. So for that we should do viral testing, sputum culture and other things. After they are telling about the potential indication for hospitalization assessment. So what are those? They are telling severe symptoms such as sudden worsening or resting dyspnea, high respiratory rate, decreased oxygen saturation, confusion, drowsiness is there, acute respiratory failure, onset of new physical sign like cyanosis, peripheral edema, failure of an exacerbation to respond to initial medical management, presence of serious comorbidities like heart failure, newly occurring arrhythmias, and insufficient home support. After that, they are telling about the management of severe but non-life threatening exacerbations. Assess the severity of symptom, blood gases, chest X-ray we should do. Then we should like administer supplemental oxygen, obtain serial ABG, venous blood gas, and we should do like pulse oximetry measurements. Then bronchodilators, they are telling like increase the dose or frequency of short-acting bronchodilators, combine short-acting beta agonist and anticholinergics. Consider the use of long-acting bronchodilator when patients become stable. Use spacer or air-driven nebulizer when appropriate. Then we should consider oral corticosteroids, consider antibiotics, NIV, and we should monitor the fluid valence. Consider subcutaneous heparin or low molecular weight heparin for thromboembolism prophylaxis. Then they are telling identify and treat associated conditions like heart failure, arrhythmia, or pulmonary embolism is there or not. Then they are talking about the management of exacerbations. So for that, we should give like a short-acting beta 2 agonist with or without short-acting anticholinergics. Like we should prefer beta 2 agonist and are recommended as initial bronchodilator to treat acute exacerbation. Systemic corticosteroid can improve lung function, oxygenation, shorten recovery time, hospitalization duration of therapy should not be more than 5 days. For like they are telling systemic steroid, we should not give more than 5 days. Very, very important. Very, very important. Yeah. After that comes antibiotics when indicated can shorten recovery time, reduce the risk of early relapse, treatment failure, hospitalization duration, and duration of therapy should be less than 5 days. So they are telling if we will give azithromycin, then it can shorten the recovery time, reduce the risk of early relapse and treatment failure and hospitalization duration. About the methylgen, they are telling we should not recommend it due to increased side effect, and NIV we should give them because it used to improve the gas exchange, reduce the work of breathing and need of intubation, and decrease hospitalization duration and improve the survival. So yeah, this is the first mode of the ventilation. So NIV should be given. Indication of respiratory or medical ICU admission. So they are telling severe dyspnea that respond inadequately to the initial emergency therapy. Change in the mental status is there. Persistent or worsening hypoxemia like PaO2 less than 40, only less than 40, and severe or worsening respiratory acidosis means like pH less than 7.25 despite supplemental oxygen and non-invasive ventilation. Need for invasive mechanical ventilation is there, then also we should shift the patient to ICU. And if patient is hemodynamically unstable and he needs vasopressors, then indication of NIV. So they are telling if respiratory acidosis is there like PaCO2 more than 45 mmHg and RTL pH less than 7.35. Severe dyspnea with clinical signs suggestive of respiratory muscle fatigue, increased work of breathing, both such as respiratory accessory muscle, paradoxical motion of abdomen and retraction of intercostal space. So first thing is respiratory acidosis, second thing is severe dyspnea and with the clinical sign, and third is persistent hypoxemia despite supplemental oxygen therapy. Then comes like what are the indication of invasive mechanical ventilation. They are telling like unable to tolerate the NIV or NIV failure is there. Then status post respiratory or cardiac arrest if patient come after cardiac arrest. Diminished conscious or like respiratory arrest. They are telling like diminished consciousness, psychomotor agitation or inadequately controlled sedation, massive aspiration or persistent vomiting is there, persistent inability to remove respiratory secretions, severe hemodynamic instability without response to fluid or vasoactive drugs, severe ventricular or supraventricular arrhythmia are there, life-threatening hypoxemia and patient unable to tolerate NIV. So in those cases, we should go for invasive mechanical ventilation. Then what are the discharge criteria and recommendation for follow-up? So yeah, they are telling like uh, full review of all clinical and laboratory data should be done. Check maintenance therapy and understanding. Reassess inhaler technique. Ensure understanding or of withdrawal of acute medication like steroid and antibiotic. So we should withdraw them. Assess need of continuing any oxygen therapy. Is there any need of continuation of oxygen therapy? Is there or not? Provide management plan for comorbidities and follow-up. Ensure follow-up arrangement. Early follow-up like less than 4 weeks are different, and late follow-ups means between four like 12 to 16 week follow-ups are different. All clinical investigations abnormalities have been identified. Then they are telling like for 1 to 4 week follow-up. So in that time they are telling like we should evaluate ability to cope in his or her usual environment, like patient can cope up or not. Then review and understanding treatment regimen, reassessment of inhaler technique, reassess need of long-term oxygen therapy is there or not, document the capacity to do physical activity, and consider patients eligibility to be enrolled in pulmonary rehabilitation. Document symptoms like CAT or MMRC grading and determine the status of comorbidities. And for like long-term follow-up, like for 12 to 16 week follow-up, they are telling we should evaluate the ability to cope in his her usual environment, review understanding treatment regimen, reassessment of inhaler technique, long-term oxygen therapy. So like all things are same till there, like no documentation of the capacity to do physical activity and activity of daily living. So they are telling like for long-term follow-up, they are telling we should do spirometry. We should check FEV1. So this is like different thing. So yeah, this is like additional thing we should do in long-term follow-up, which is spirometry. Then they are talking about the interventions that reduce the frequency of COPD exacerbation. So like bronchodilators are like LABA, LAMA, LABA plus LAMA combination. Then corticosteroid containing regimen like LABA plus ICS, LABA, LAMA plus ICS. Anti-inflammatory phosphodiesterase stage 4 inhibitor are like roflumilast. Then anti-infective means vaccinations and long-term macrolide like azithromycin or erythromycin. Then they are talking about the mucoregulator like N-acetylcysteine, carbocysteine, and aldocysteine, and various other things like smoking cessation, rehabilitation, lung volume reduction, vitamin D, shielding measure like mask wearing, minimizing social contact, and frequent hand washing. What are the common risk factor for development of cancer? So they are telling like if age is more than 55, smoking history is more than 30 pack years, presence of emphysema by CT scan is there, presence of airflow limitation means FEV1 upon FVC is less than 0.7 is there, BMI is less than 25 kg per meter square, and family history of lung cancer is there. So these are the factors which are the like common risk factor for development of lung cancer. Means age less than more than 55, smoking history more than 30 pack years, emphysema, presence of emphysema by CT scan, presence of airflow limitation means ratio less than 0.7, BMI less than 25, and family history of lung cancer is there. Then they are talking about the key point for management of stable COPD during COVID-19 pandemic. So what are the protective strategies? So follow basic infection control measure, wear a face covering, consider shielding and sheltering in place, have the COVID-19 vaccination according to national recommendation. Then we should do like investigation if any signs symptoms of COVID-19 are present. Then they are talking like if there is high prevalence of COVID-19 in that area, then we should not do spirometry, and spirometry is suggested only in essential cases. Then pharmacotherapy, ensure adequate supply of medication should be there, continue unchanged ICS, like ICS we should continue. Non pharmacological treatment, they are telling like we should ensure annual influenza vaccination and maintain physical activity. After that, they are talking about the COVID-19 and COPD. So like clinical features are like cough and like dyspnea is there. Then they are talking about the, this is like COVID COPD patient which is not infected. He will have like cough and dyspnea. After that, if he will have mild COVID-19, then mild constitutional symptom like fever will be there, like temperature will be more than 37.5 degrees centigrade. Dyspnea will be there, dry cough, fatigue, diarrhea, these things will be there. And they are telling like SARS COVID, uh, like we should do like COVID-19 test, then chest X-ray, CT, saturation, lymphopenia, thrombocytopenia, CRP, D dimer, these things we should do. And like what are the possible interventions? So they are telling we should uh, do like protective strategies, COPD exacerbation therapy, low intensity exercise should be recommended, and therapeutic trials we should start. After that comes dyspnea and infiltration. And like patient is having COVID-19, he is having like dyspnea and infiltration. Like dyspnea will increase a lot, hypoxia will be there, and PaO2 upon FiO2 will be uh, less than 300 mmHg. Yeah. Then they are telling like in that condition also we should do like chest X-ray, saturation, lymphopenia, thrombocytopenia, transaminases, and D dimer and PCT. Then they are telling like controlled oxygen we should give, systemic steroid, remdesivir, anticoagulation, and therapeutic trials should be started. Then comes ARDS stage, which is like SIRS, or shock or cardiac failure could be there, or ventricular thromboembolism could be there. Then they are telling like we should do like these things. They are adding like ferritin, IL-6, LDS, CRP, troponin, and BNP levels, and NIV should be given, HF. Yeah, and like high flow nasal therapy should be given, and invasive mechanical ventilation should be considered. Then prone positioning, anticoagulation, therapeutic trials should be started. Then comes convalescent COVID. So for that, like fatigue, dyspnea, cough will be there, PFT and CT chest we should do, and home based exercise and pulmonary rehabilitations are recommended. After that, they are telling like key point for management of patients with COVID and suspect or proven COVID-19. So they are telling like yeah, they are telling like swab, saliva, PCR. If new or worsening respiratory symptoms are there, or fever is there, or any other symptom that can be related to COVID-19, then we should do COVID-19 testing. For other investigation, they are telling avoid spirometry until it is essential. Consider CT for COVID pneumonia to exclude other diagnoses like pulmonary embolism. Avoid bronchoscopy unless essential. Assess for co-infection. So like we should like check, we should assess for co-infection, and we should do CT scan, and we should avoid spirometry and bronchoscopy. Then comes their for pharmacotherapy, they are telling like we should ensure adequate supply of the medication to the patient, continue inhaled corticosteroid, use antibiotic and oral steroid if they are recommended for exacerbations, and avoid nebulization when possible. If it is possible, then we should not give nebulization. Very, 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 very important. We should use inhaled corticosteroid and antibiotics and oral steroid. Then they are talking about the non-pharmacological therapy. Then we should maintain the physical activity as possible. Uh, Protective strategies, they are telling like we should give them COVID-19 vaccination according to national guidelines, follow basic infection control measures, maintain physical distancing, wear face mask. Then they are talking about the COVID-19 therapy. So we should use antiviral, corticosteroid, IL-6 receptor blocker, baricitinib as a recommended for patient with COVID-19. Baricitinib. Use high flow nasal therapy and IV for respiratory failure if possible. Use invasive mechanical ventilation if these things failed. Then they are telling about the post COVID-19 rehabilitation we should do, and ensure appropriate post COVID-19 follow up. Then they are talking about the COPD follow up checklist. So yeah, there is like recommended COPD follow up checklist. So here they are telling like follow up could be like either in person follow up, phone follow up, or virtual follow up. So this is like column for date, for diagnosis, then baseline symptoms we have to check. We have to check like breathlessness on a regular day. Like we should check like what is the MMRC rating on a regular day. Then we should check daily sputum production is there or not. What is the color of sputum? Then we should check like regular cough is there or not. Then is there any change in the symptoms? If change is there or not. If yes, then we should proceed further. Like we should check the sputum color, dyspnea increase or decrease, cough increase or decrease, sign of hypercapnia are there, sputum volume increase or decrease, fatigue increase or decrease. According to that we should check like CAT scoring, COPD assessment test score. ठीक है. After that they are talking about the maintenance, medication and adherence, like LAVA plus LAMA, LAVA plus ICS or triple combination is there. Other like we should check like non-pharmacological treatment like oxygen, CPAP, BiPAP. After they are talking about the COVID-19 column, if patient is feeling unwell, then we should check other symptom like fever is there, sore throat is there or not, anosmia is there or not. They are telling like contact with someone COVID-19 positive, yes or no, tested for COVID-19, yes or no. Then they are telling like written action plan is there or not, like patient is having written action plan or not. And like if they are already having, then we should like check like what was the last time when it was given. Then recent admission and emergency visit, we should like add these things also and comment on them. And then we should check like COPD self management healthy behaviors. So smoking free environment is there, medication adherence is there or not, prevention management of exacerbation, breathing control, stress management, physical activity and exercise, and other features. Then we should check like what is the main issue and summary and intervention plans. After they are talking about the like we have discussed a lot of times evidence categories. So there are like four evidence categories: evidence category A, B, C, and D. So evidence category A is like very like confirmatory. So we should like check them. What are those? So they are telling like what is the source of evidence in evidence category A. So randomized controlled trials are there, and rich body of high quality evidence. So high quality evidence is there without any significant limitation or bias. So there is no bias and like high quality evidence is there. And what is the definition of RCT? We know like evidence is from endpoint of well-designed RCT that provide consistent finding in the population for which the recommendations is made without any important limitations. And they are telling require high quality evidence from more than 2 clinical trials involving substantial number of subject or single or high quality RCT involving substantial number of patients without any bias. So these are like evidence category A. Then comes category B, which is having like RCT with important limitation is there and a limitation body of evidence is there. Then comes category C. Here we do like only non-randomized trials and observational studies, and these according to panel consensus judgment. So there is no like proper data available or subject is insufficient. Then they are talking about the FEV1 trajectories over the life course. So yeah, they are talking like there are like four FEV1 trajectories we can see here. So trajectory 1, 2, 3 and 4. So like we can give them number 1, then this is 2, then this is 3 and this is 4. So they are telling like trajectory 1 is normal, like lungs are normal and there is no feature of COPD. Then comes this trajectory 2. Trajectory 2 says that patient is having small lungs. Yeah, patient is having small lungs but there is no COPD. Sorry, this is trajectory 2 and this is 3. So trajectory 2 is like patient is having small lungs but there is no COPD. Trajectory 3 is like patient is having like normal lungs. This one, this is trajectory 3. Here patient is having normal lungs but patient is having COPD. And category 4 is like patient is having a small lung and patient is having COPD. So like most of the patients are not having COPD and like out of them 71% are most of the population is having not having COPD, and like most of them is like having normal lungs, and there is no COPD, and like 16.9% patients, people are there who are having like a small lungs, but they do not have COPD. But they are telling if they are having like a small lungs, then like there are high chances of having COPD, because out of them like uh, one third patients are having COPD. So we will go proceed further. So they are talking like, yeah, this is the end of the this class. Thank you so much.